Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody, wherever you are, with this very pleasant lecture with our professor, Dr. Tarek Katamish from Egypt. I don't need to introduce him again. He is very well known. He is a pioneer in the cornea in general and in the lamellar keratoplasty in specific. Today, Professor Tarek will give the talk of different bubbles, different troubles in Big Bubble DALK. And I would like as well to welcome Dr. Bara Qubaisi and thank him for being with us today to moderate the session. And of course, I would like to thank the attendees for giving some time from their valuable time to attend with us and ask us the questions that we all learn from. Thank you very much, everybody, and let us start. Professor Tarek, the stage is yours.
Okay, I will share my screen now.
Sorry, I didn't. Yeah, now I give you the permission. Yes, please.
Yes. It's clear now?
It is.
Yes.
Okay. First of all, I would like to thank Dr. Mazen for his kind introduction. And I will speak today about different bubbles, different trouble. Before I start, I would like to thank again the esteemed Dr. Mazen Sinjab, the founder of the Sinjab Academy, for his continuous efforts and persistent, sincere work to bring us all on this platform to exchange information and education to the younger generations. So again, thank you very much, Dr. Mazen, for your valuable efforts.
Thank you very much, Dr. Tarek. I'm sure nothing can happen without your support. Thank you very much.
Thank you very much. I will start directly about my topic today, which is different bubbles, different troubles. I think that this article, The Human Corneal Anatomy Redefined, a novel pre-Desmus layer, Duas layer. This article have made a revolution in our understanding of the mechanics of the big bubble formation. And I have the honor to be one of the friends of Professor Herminder Dua, the founder or the descripting of this anatomical layer. So this is the Dua layer. As you see from the diagram, it is just in front of descemet membrane. That's why we call it the predesmatic layer. As you see, it is just about 10 to 15 micron, which are the last layer of the stroma just in front of descemet membrane. So according to this new predesmatic layer or the Duas layer, we have three types of big bubbles. The first one is the big bubble type 1 with a very characteristic white edge. We will see other features for this bubble when we go through the details of it. And it represents about 85% of the big bubbles. The second type is type 2, in which we have a bubble with a clear edge. I'm speaking about the edge and not the bubble itself. So we have type 1 with white edge and type 2 with clear edge, as you see from this image, which represents about 10% of the whole big bubbles. And we have a third type, which we call it big bubble type 3, or the most popular name is mixed big bubble, in which we have the two types of big bubbles in the same eye. And this somewhat very rare, and it represents about from 3 to 5% of the whole big bubbles. So to start understanding the different features and the anatomical plane of the big bubbles, I will start by big bubble type 1. This is a video animation of big bubble type 1. As you see, it usually starts from center to periphery, as you see. And the maximum diameter of this big bubble is 8.5 millimeter because of the strong attachment of Dua's layer to the stroma at this point. This strong attachment resists the enlargement of the big bubble, and this point is the cause of the white color of the edge, because the bubbles are trying to spread, but it cannot spread. So there is a lot of emphysema at this circle. That's why we have a white color of the edge. And as you see, it is quite clear that the plane of separation is between the stroma in front and the Dua's layer behind. Clinically, as I have mentioned, you will find this bubble have a characteristic white edge. This is the characteristic white edge. I am speaking about it. This is the attachment of Dua layer to the stroma, and this white color because of the emphysema in this site, because the air have trying to escape beyond, but it is trapped at this site. In the operation, when we do debulking of the stroma or we remove the stroma, we'll be having the floor. We call this the floor of the big bubble, and it is formed of 3 layers, as you see: Dua layer, desmoid membrane, and endothelium. And Dua layers is characterized by being rough. You see, it is rough surface. This rough surface is highly characteristic of type 1 big bubble. So to summarize again, type 1 big bubble usually starts from center to the periphery. Number 2, it has a maximum diameter of 8.5 millimeter. Number 3, it has a characteristic white edge. Number 4, when you remove the stroma, you will be having the floor is having a rough surface. Other examples to explain the bubble more, as you see, this is the big bubble, and again, it is quite clear, the white edge. And after you remove the stroma, you will be having again this rough surface characteristic of the predesmatic Dua layer. Another example, characteristic white edge, as you see, and the very clear or very apparent rough surface, especially when it is dry. When you make wetting, it will be smooth. So we have to judge the surface of the floor of the bubble after drying it. So when it is dry, it is very rough, as you see. These are another 3 examples of big bubble type 1, again with its characteristic white edge. There is some phenomena, or I can add here something to big bubble type 1, that when you are injecting very deep, as I always advise, there is no time for the emphysema to form and then to have the bubble. So you are injecting very deep, so you'll be having the bubble immediately without any emphysema. I call this the transparent big bubble. I want to differentiate between 2 things. This is a white edge of big bubble type 1. This transparent big bubble, because there is no time for emphysema formation, because I'm injecting very deep. Again, example again, you see, when you inject, you will be having the bubble immediately without any emphysema because you are injecting very deep. Another 2 examples, injecting, usually we have emphysema going here and there, and then suddenly you find the bubble is forming. But if you are injecting very deep, as I always advise, you will be having the bubble immediately without any emphysema. This means that you are very, very deep and very close desmoid membrane. So if we go to big bubble type 2, we will find a great difference in the characteristics. So we call this bubble the predesmatic big bubble, because its location is just behind Dua layer and just in front of desmoid membrane, as we will see now. So big bubble type 2, it usually starts from periphery to center. You see, it starts from periphery to center. Why? Why big bubble type 2 starts from periphery to center? The answer from these drawings, if you can watch, these are fenestrations. This is the endothelium, and this is the blue line is descent membrane, and the red line is dual layer. These fenestrations in dual layer will allow air to escape from this stroma to this fenestration and make bubble 2. So to have bubble type 2, always air escapes from the periphery. So when you inject air, you will be having this air escaping and making separation of this membrane, forming big bubble type 2. This is the explanation of why big bubble type 2 usually starts from periphery to center. So again, big bubble type 2 starts from periphery to center, and there is no limiting anatomical factor for this bubble to expand. It may reach up to 10.5 millimeter, or it may reach from limbus to limbus, because there is no attachment of the stroma, as I have mentioned with type 1. Again, it's clearly seen here that the plane of separation, the bubble is between the two membranes, the descent membrane behind and the duous layer in front. That's why we call it the predesmatic big bubble. If you inject air, you will find that the edge is clear. You see, the edge is clear. If you compare this with type 1, it's quite clear that the edge, sometimes we call it the glassy big bubble, because the edge, I'm speaking here about the edge, not the whole bubble. The edge, what's important for me is the edge. So this clear edge is characteristic of big bubble type 2. Before understanding the mechanics of big bubble DALK, we have thinking of this that may be a bubble in the anterior chamber. But when we have known about the different types of bubble, we recognized that this is not a bubble in the anterior chamber, it is a big bubble type 2. When you remove the stroma, you will be removing the duous layer with the stroma, and you will be having only two layers, the endothelium and basement membrane, which of course is a very fragile tissue or very fragile floor. And again, when you open the big bubble roof, you will be having the floor, as you see, featureless or very smooth, because dual layer have been excised with the remaining stroma. So again, big bubble type 2 has characteristic clear edge, and again, it has characteristic smooth surface, as you see, if compared with type 1 big bubble. Another example, you see a very clear edge. I'm speaking about edge, not this area. This is a bubble. I am speaking about the edge. The edge is clear. And again, the floor is very smooth, as you see. These are another 3 examples of big bubble type 2 with its characteristic clear edge. We come now to a more complicated mechanics, what we call the mixed big bubbles. We have 2 types of mixed big bubbles. Either we have mixed big bubble in which we have complete big bubble type 1 in yellow color, as you see, and another small partial, sorry, if you may have a complete big bubble type 1 and another small partial big bubble type 2. This is the commonest type of mixed big bubble, a large big bubble type 1 and a small or partial type 2. The very rare example is to have 2 complete big bubbles behind each other. So this is a big bubble type 1 in the center, and there is another big bubble or complete big bubble type 2, which is very rare example. I will show it to you now. So these are very complicated mechanics, and you have to be aware of all these types. So this is an example of big bubble type 1 complete and partial type 2. You see, when you making the injection and you remove big bubble type 1, you will be having another bubbles. You see, these is small bubbles. These are bubbles type 2. So this is an example of mixed big bubble having complete big bubble type 1 and partial big bubble type 2. I will show another examples to understand more and to have more clear idea about this type. You see, this is the big bubble type 2 after opening big bubble type 1, and this is air in the anterior chamber. I will show it to you now. When I open this, you will find this air in the anterior chamber will move centrally, because you see this bubble is intended, because the bubble type 2 make it to a periphery. So I will play the video now. You see, this is a big bubble type 2 and this air in the anterior chamber. You see this bubble type 2. So this is partial big bubble type 2. I will go now and open this bubble. Watch carefully what will happen to the bubble in the anterior chamber. It will move, and you see it moved again by slow motion. It moved to the periphery. So this is a clear example of having big bubble type 1 complete and partial big bubble type 2. Another example, this is the picture for the other example. Another example, watch carefully here, just emphysema, and you don't know what's happening, what's going on. Then you will open type 1, you will be having another big bubble type 2. This is a big bubble type 2, not air in the anterior chamber. Okay, this is a partial big bubble type 2, as you see, and you can go and just open it. This another example of mixed complete big bubble type 1 and partial big bubble type 2. This is after we open type 1, we'll be having another bubble here. You can watch this small bubble in the anterior chamber. If there is nothing here, these small bubbles should be in the center. So you see, this is a big bubble type 2. The arrows showed it, and I will open it now. You see the small bubbles. I will make it slowly again. So this is another example. I am now putting my spatula directly under DOA's layer, because this bubble was between DOA's layer in front and this membrane behind. I will go to the most complicated mechanics, which is complete big bubble type 1 and complete big bubble type 2. Please be concentrating with me during this one and a half video clip to see what's going on. So this is big bubble type 1 with a very clear white edge. See? Watch carefully what's going on behind. So this is big bubble type 1, as I have mentioned. And there's another edge here, clear edge. This clear edge is big bubble type 2. So I will make my paracentesis. Watch carefully. When you do paracentesis, you will find expansion of this big bubble type 2. Watch carefully here. You see this bubble 2 have been expanded because we relieve pressure from the anterior chamber. So we will go and do our lamellar dissection, and we will do what I call it the first brave slash. We will be having 2 brave slash in this situation. When you do the brave slash, we will still have something shiny here behind it. So you thought that you have only one bubble, but actually we have something going on behind it. I'm cutting the stroma. You see there is undulation of this membrane behind, and there is another complete big bubble type 2 filling the whole eye. So I will go now to do what I call it the second brave slash. I have to open in this example 2 big bubbles. So I will go now and open the second big bubble. Now we'll be having this an opening in DOA's layer, and this rough surface of DOA layer, and this smooth surface of this membrane. If you look to this video as if you are looking to a textbook of anatomy, this is a very rare example of having 2 big bubbles in the same patient. Another example, but not as clear as this, injecting air, having big bubble type 1, opening the roof and injecting air again in the anterior chamber. You will be having another bubble, and you are now under DOA layer. The spatula now is under DOA layer. You can cut through DOA layer, but of course our aim is not to cut DOA layer. But this video was very old, about 10 years ago, before the introduction of this layer, and at that time it was not clear for me that this is DOA layer. But now if I have 2 big bubbles, I just open the second bubble, but I don't remove dual layer. So this to show the difference between Big Bubble type 1 with its rough surface and Big Bubble type 2 with its smooth surface. Why we are spending too much time in understanding the difference between these two types? Because as you see, this type or this floor is very strong and very tough. So you can work very easily at ease. You can make cutting the stroma very easily. You feel comfortable dealing with this type of big bubble. But if we have this bare descent membrane, which is very fragile, as we will see now, so you have to work very, very carefully. Otherwise, you will rupture descent membrane from the slightest trauma. So it is very crucial for us to recognize which type of bubble we are dealing with. So this to show you the toughness of dual layer. This by mistake, I will do it again by slow motion. So see how much pressure is applied, and still dual layer is resisting rupture. So how much pressure is applied? So this gives you an impression that dual layer is very strong. From this point of view, to know that dual layer is very strong, we can use this information in doing triple phaco DALK. If you have, for example, combined stromal opacity and cataract, you can do both in the same sitting, and you can start doing DALK first. So this is a combined case of nuclear cataract with keratoconus. I will start doing the big bubble DALK. You see this big bubble type 1, and then we will do the usual steps, delaminating the stroma, the brave slash, cutting stromal flaps, and then you will be having the dual layer as you see. This dual layer allows you to do phaco through this 20 micron or 15 micron layer. So you see that the tough surface and the rough surface. I will go now to do my cataract, injecting Helon, making Tiriban blue staining, making my usual wounds with counter pressure with Colibri Forcer, capsulorhexis. So you are doing all the steps of phaco through this layer, because you know that it is a tough layer, making nucleus rotation, hydrodissection, making the grooving, starting the phaco, nucleus fracture. You see, it can withstand all these maneuvers because it's a very tough layer, making chopping technique. Can you imagine that you are working through just a layer to 15 macron layer, because it is very tough, making irrigation aspiration, and even you can implant your intraocular lens and making it in the bag, and finally you can put your graft and suture it. So thanks for the tough properties of dual layer that allows us to do phacoemulsification through it. On the other hand, the descent membrane is very fragile, and type 1 big bubble is very fragile. It ruptures on the slightest trauma. So you have to be very, very careful while dealing with such a type 2 big bubble. This comes with my first part of my talk. I will speak now about the different troubles during the big bubble formation. Of course, if you are following certain technique, which I have described in my last lecture, you will be able in a 90% of cases to get the big bubble from the first injection, as you see, if you are following the tips I have shared before. But sometimes the first trouble is that you may not be able to have the bubble except you have repeated injection. So this is the first trouble which you may encounter during your DALK cases. So this is the first injection, emphysema, second injection, third injection, emphysema. Again, this will have the bubble at the fourth injection. So as I always say, you have to be patient and determined until you get the big bubble. Of course, if you failed to get the big bubble, you can convert to the manual technique. And I think this may need a special lecture. So I am asking Professor Dr. Mazen now that we should have in our program to have a separate lecture for demonstrating the manual DALK technique.
Yes, sure,
The
doctor. Sure, professor. Inshallah.
thank you, Nazim, for your kind response. The second trouble which you may encounter is what I call it, as you mentioned, I have as you see, I am calling it troubles. It is not true complications, just troubles you may face during your DALK operation. Of course, our aim during DALK or big bubble formation is to have the big bubble across the terrifying edge. But sometimes you find that the bubble does not want to expand enough. As this example, you see, when you're injecting air, you find this edge not able to enlarge. So you have to keep injecting until suddenly you will be having the bubble behind the mark. Another example, you see injecting, the bubble is coming up, but here this area is not well covered by bubble, so don't lose force, keep injecting until you will find suddenly the bubble enlarged. A good tip is that when you have this phenomena, this means that the pressure inside the eye is too high for the bubble to expand. So a good tip I have learned from my colleague Rajesh Fogla in India, he stopped during air injection, make paracentesis, and then inject again. So watch carefully this bubble. You see, it doesn't want to enlarge. So stop, come out, stop, make paracentesis to lower tension, and go again and inject. You will find it is very easier to enlarge the bubble if you have some resistance. The third trouble or phenomena is what I call it expansion of the big bubble type 2 by paracentesis. This is a big bubble type 2, as you see, a very large bubble, clear edge. If you do paracentesis, be careful, because during paracentesis, the aqueous comes out, the tension becoming low, and the bubble expands. Watch carefully. This is the bubble. When you do paracentesis, it will expand. You see? It expands to the extreme periphery. So you have to be careful if you may injure the bubble by yourself. Another example of the expansion of big bubble 2. This is a big bubble type 2, as you see, with clear edge. Watch carefully at this area when it expands tremendously. You see this huge expansion. If you are not aware by this phenomena, you may injure the bubble from the inside by yourself. So this is what I call it the third trouble. The fourth trouble is the burst big bubble. If you are injecting air, of course, the Dewey's layer and this membrane has certain pressure. Beyond it, it may rupture in the anterior chamber, especially if you have a scarring of this membrane, if you have a minute hydrus before. So as you see from this example, injecting air, so my advice, don't use too much pressure during air injection. Otherwise, you will be having this phenomena, big bubble, and then it will burst in the anterior chamber. I will show it again. You see, big bubble formation, and then it bursts in the anterior chamber, and the air will go out, and the bubble will collapse. Another example of burst big bubble. This is the first example. It's formed and then ruptured in the anterior chamber. Again, it's formed and then rupture the anterior chamber. Again, the same. And sometimes you may hear a clicking sound of this rupture. You'll be astonished that you will hear the sound of this membrane rupture. This is another example of burst big bubble, but this is partial. There is minute rupture which allow part of the air to come out, and the other part of the big bubble is still there. You see this? You see? The bubble is come, but still it is trapped in the periphery. This means that there is still big bubble half filled and half ruptured. Another example of partial big bubble, you see type 1, and then it will rupture. Through a minute rupture, air will escape, as you see, but very minute rupture allowed some of the air to escape, not the whole air. This I call it partial burst big bubble. Many of the terms I am using in this presentation is my own terms. I have the honor to be the first one to describe these situations. So if you have intacs, in your keratoconus cornea, sometimes we have some troubles in doing DALK with intacs. The first trouble is, as you know, we are always doing the intacs tunnel with excimer laser, with the femto laser, or sometimes it have been done in the past days by the manual technique. So you may have some minute defect in this membrane. So you may expect to have this burst big bubble, as I have mentioned before, because of minute defect in this membrane, and sometimes because of the intacs, it has some resistance for the bubble to expand. As in this case, if you see, there is some resistance to expand, and then again, if you inject more and more air, you will be able to have the bubble to expand. These are some troubles which may occur if you are doing intacs in a patient with keratoconus. The last trouble, I call it the tricky situations. Some tricky situations, you have to be aware of it to recognize it during the operation. If you are not aware of these situations, you will not be able to diagnose it during the operation. This is what I call the collapsing big bubble, and I have the honor again to be, to the best of my mind, to be the first one in the world to describe this collapsing of big bubble. So when you inject air here, you will be having big bubble type 1 with white edge. But when you are going out, you see the air comes out with you through a leaking tract. So you are confused. Do you have bubble or not? The small bubble test is negative. So what's going on? You see, the bubble is present but hidden. When you go and inject air again, it is there but hidden. The solution for this situation is you go and inject viscoelastic, because we have a leaking tract, and if you are going out, the air will come out with you. But to solve this problem, you have to go and fill your big bubble space by a viscoelastic to have the space maintained. Another example for this tricky collapsing big bubble, watch carefully, this type 1, and then when you are going out, watch carefully, the air will come with you. You see, the air is coming with you. And this is the reason for this phenomena. You have a wide tract in which air escapes. So your eyes should be very alert to this phenomena to diagnose this tricky situation. Unfortunately, this is not a common situation. Again, this is a very clear example of what I mean by collapsing big bubble. Watch carefully this example. Injecting air, you have the bubble, and then it collapses. I will do it in slow motion to be more clear. You see now, I inject air, I will be having the bubble, you see, and when you are going out, it comes, all air comes out with you, you see. That's why when you do now the small bubble test, you will find the small bubbles are in the middle, not in the periphery. So you have the big bubble, but it is collapsed. So why it is crucial to diagnose such situation? As you know, in the ordinary way, we do stromal debulking and open the roof of the big bubble. We have the roof away from this membrane. So we are making the brave slash. If you have collapsed big bubble and you don't diagnose it, and you think that the bubble is still here, you will go and you do your brave slash, and you are not realizing that this membrane is touching the roof. So we will cut the two layers together and you will be having a descent membrane tear. That's why you should diagnose this situation, and it does not allow it to do the brave slash in this situation. As I have mentioned, you can reform the big bubble space by a viscoelastic before making the brave slash. The last category of the what I call it the premature or the unintentional opening of big bubble roof. This also a tricky situation. So what I mean by this, we all know, as I have just mentioned before, that this is the ordinary way of opening the roof. We make stromal debulking first, and then we go intentionally opening the roof by super blade. We call it the brave slash. But sometimes the roof opens unintentionally. I am not intending to open the roof. It opens accidentally or prematurely, as you will see in these three examples. This is the first example. At the very beginning, we are doing the section. You have opened the roof, so you have to go again and inject a viscoelastic inside the big bubble and continue your operation. This have happened very early in the very beginning of this section. It may occur prematurely in the middle of the way. You see, we have now making half of this section, but watch carefully. You will open the roof now. The air have escaped. So you have to change your strategy. You have to find this opening, and you have to make cutting of the stroma, and don't ever do the brave slash. The last example is very unique example. Watch carefully for these small arrows with the small air bubbles in the anterior chamber. These small bubbles in the anterior chamber are trapped in the periphery because there is a big bubble here occupying the whole anterior chamber. So during this section, watch what will happen now. At the very last moment of the section, watch, you see, oops, the bubbles have moved to the center. This means that you have encountered a very small perforation of the roof. So you have to stop, you have to look carefully for this tiny opening, and you have to change your strategy. And if you go blindly and do the brave slash, you will definitely damage this membrane. So again, why it is crucial to diagnose such a situation. As I have mentioned, if you go undiagnosed, you will have a premature roof opening, and you will go making the brave slash, and you will damage this membrane by yourself. At the end of my presentation, just want to reassure you that whenever you have big bubbles, it is not necessary that you should have troubles. You may make the operation most of the cases without any troubles, but you have to be aware of these troubles because when you face it and you are aware of it, you can know how to manage it. Again, this is my contacts. I think all of you know it. You can communicate with me through email or through the Facebook, or I have my own YouTube channel, or you can communicate with me through WhatsApp, or of course, you can communicate with all of us, communicate through the great platform of Sinjab Academy. And I would like to thank again once more Dr. Mazen for giving me the opportunity to be with you today, and giving me the opportunity to be in this year through the prestigious Sinjab Academy. And thank you all for your kind attention, and I am ready for any questions. Thank you.
Thank you very much, Professor Tarek, for this amazing presentation, as usual. By the way, the picture that you showed about me, it was 22 years ago.
But it's still as if you are today. You are still young and full of strength and full of passion and full of enthusiasm.
Thank you very much. Alhamdulillah, Jazakallah kul khair. And now let's open the discussion. Dr. Bara.
Unmute yourself, Bara.
Thank you, Dr. Mazen. I would like first to thank Dr. Tarek for this wonderful, well-organized lecture. I mean, I read a lot about the difference between type 1 and type 2, but you usually don't see this much of videos, and you don't get your eyes to know exactly what's happening. So many thanks, Dr. Tarek.
Thank you.
So I would like to also thank you for the title. It's an amazing title. yeah, that's different troubles for a big trouble, big bubbles. And I think that, as you mentioned, there are a lot of terms that you first described. So I don't know. I mean, you can do a textbook or an article, and for the copyrights, you can just assign them to yourself. So the first question that one of the attendings is asking, do you inject any type of viscoelastic?
As you know, there are two different types of two ways of obtaining the big bubble, either using the air or using the viscoelastic. As much as I understand, so we call it this visco bubble. This is another technique. I don't have an experience in doing visco bubble. I am just doing big bubbles using air. But I don't know if she is meaning I'm injecting, for example, viscoelastic in the big bubble space to open the roof. Even this, I don't use any viscoelastic in my technique. I prefer the dry technique. I make the brave slash and cutting the remaining stroma without using any viscoelastic. So if she means this, I don't use viscoelastic. And if she means the visco bubble, I don't have any experience with visco bubble.
I think she wrote the question when you were talking about when the air escaped while you were getting out.
Yes.
And you injected in, maybe
yes,
that was the
I'm
question.
using viscoelastic at this situation only because the big bubble has a leaky track. So whenever you reform it, it still escapes. So you want to continue your operation, you want to open your roof, so you want to have your big bubble again. So the only way is to use viscoelastic because the viscoelastic will not escape through this tiny leaking track.
And do you prefer any type of viscoelastic? Or it's okay to use
cohesive viscoelastic because, as you know, some blame viscoelastic may be a cause of double anterior chamber. So if you are using dispersive viscoelastic, it may stick to this membrane and make a double anterior chamber. So it is very easily to wash a cohesive viscoelastic. So in the very rare occasions I'm using any viscoelastic in DALK, I'm using, of course, the cohesive viscoelastic. The same principles also goes, but this is a different issue when you are doing DMEC. When you are doing DMEC and you want to do dysmatorexis, you always use a cohesive viscoelastic to be easily washed because the dispersive viscoelastic will stick to the stroma and prevent the attachment of this membrane.
Yes, thank you. So one is asking, ideally, which is better, type 1 or type 2? And I want to add a small phrase. Is it visually better, or is there any rate of lesser rejection, maybe?
No, of course, the first part of the question, which is better, type 1 or type 2? The answer, of course, is type 1. Why? Because type 1 has dual layer. Dual layer is very strong and can withstand the dissection and the maneuvers I'm doing. But if you're having type 2 dual, the big bubble, it is very fragile and it ruptures on the slightest trauma. So I have to be very, very, very cautious during dealing with this type. This is the answer of the first part of the question. The second part of the question, please, can you
visually and rate of rejection between both?
Yes, for the visual difference, I think there is no published data, or there is a few published data, and I think there is no difference between the visual potentials in both techniques. Either you have by type 1 or 2. And as regard the rejection, of course, we know that DALK, whether you have type 1 or 2, do not have any endothelial rejection. But of course, you may have stroma rejection. So stroma rejection is possible either you are having big bubble type 1 or 2 because the whole stroma is the main issue as regard the stroma rejection. But since you are removing the endothelium, so you will not be having endothelial rejection whether you have big bubble type 1 or 2.
Great. So if we had mixed bubbles, type 1 and type 2, can we leave the second bubble, or we should rupture it?
If the second bubble is actually, most of the surgeon they were confused before about this small bubble, and they leave it and to absorb alone. So if you have a very small bubble, second bubble, you can leave it. But if you have a very large second bubble, it is very difficult to leave it because the tension will be high. So just advise you to just puncture it. Even there is no need to make the brave slash as I have shown, just puncture it to collapse the space. But if it is small and partial, you can leave it. If it is large, you just puncture it.
Someone is asking, how can I make difference between mixed bubble and burst bubble?
No, the difference is, the question is very strange to me. The burst bubble, that you have a big bubble type 1, and then where you are injecting, suddenly you will find air escaping out of the big bubble that you have seen in front of you, and you will be having this burst bubble in the anterior chamber moving. This is completely different. But if you're having mixed big bubble, you may either diagnose it in 2 different stages. When you inject big bubble type 1, you will be having the white edge, and you will be having another white edge extending to the periphery, and it has different look than the bubble going inside the anterior chamber, and it is fixed, not mobile, like bubble anterior chamber. This is the first presentations. The second presentation is that you have big bubble type 1, a lot of emphysema, you don't know what's going on, and you open you make a stroma dissection, open the roof of type 1, moving stroma, and then you will be astonished that you will be having another bubble at this stage, and this bubble is fixed, not mobile in the anterior chamber. So the question, this is the first time someone to ask me this question: what's the difference, how to differentiate between mixed big bubble and type and burst big bubble? So if you are working and if you have some experience, you will find this is very easy to differentiate between these 2 situations, as I have mentioned.
Another question is, does rupture of the big bubble means it was type 2? Maybe he's
not necessarily.
referencing to...
No, not necessarily. I have shown a lot of examples that even one of these examples, it was live surgery. I was invited to Czech Republic to do live surgery in their country, and I was so proud of myself doing the bubble and getting the big bubble type 1, very confident, and suddenly it ruptured. So it's not necessary, but to have rupture of big bubble to be type 2, because as I have mentioned, if someone is following me, I said this ruptured bubble or burst bubble usually have previously, if you examine the patient properly, you will be having a scar in this membrane, which is a very weak point, which cannot withstand the pressure. Or you may be having a very minute previous hydrops, which is sealed and leaving a tiny scar. So the bubble forms, and then when it reaches this weak point, it ruptures. And usually it is type 1, not type 2.
Someone is asking about the parameters, if you want to do phacoemulsification during the DALK, as you said.
Yes, this is a great question, because most of the people think that I am working through a tiny layer, 15 micron. I have to lower the bottle, I have to lower the vacuum. For myself, I have told myself I will try the ordinary parameter first. It was very strange to me that I am working in the ordinary parameter and everything was okay. And as I was working with the ordinary parameter, the bottle height as usual, the vacuum as usual. But of course, I was ready to change or lower the parameters if I find I'm not comfortable. But to be honest with the audience, I have only experience of 2 cases only of doing triple phaco-DALK. I am not expert in this area. I've just shown the video to demonstrate the toughness of dual layer. But for my 2 cases, I have done only 2 cases. I have using the ordinary phaco parameters.
Great. Someone is, I mean, all of the audience are thanking you. Someone is asking, can we practice this big bubble at goat's eye in wet lab before starting in humans, or do you prefer
no.
any?
I think no. I have organized and I have attended a lot of DALK wet labs, especially if you are following the SEXU meeting in Italy every year. I am organizing a wet lab every year in SEXU meeting on DALK, and we usually use human corneas mounted on artificial anterior chamber. So I don't think that in sheep's eye or pig's eyes you will be having the big bubble. But you can, if you want, you can practice injecting air, looking to the emphysema, trying to practice the lamellar dissection, layer by layer dissection, manual dissection. But I don't think that you will be able to get the big bubble except in the human corneas, to the best of my knowledge.
Great. Last question, what are the causes of burst bubble? Is it just the maneuvers?
I have mentioned in my talk, and I have mentioned now, that the most probable cause that you will be having a small area of weak descent membrane, either a scar or a previous undiagnosed hydrops, or sometimes if you are injecting too much, there is some studies about the pressure which could be withstood by the descent membrane or Dewey's layer. So if you exceed this pressure, you will definitely rupture. But in the ordinary cases, I think the main cause for rupture is the scar in stroma reaching or entangling part of this membrane, making it fragile and weak. Or if you have a healed hydrops which is undiagnosed and leaving a minute opening which allow air to escape in the anterior chamber.
In the mixed bubble, Dr. Tarek, if we have a complete two bubbles, does it is it related to the depth of the AC, or
no,
maybe
no.
like in
the mixed big bubbles, I think in my experience, has a relation to two things. The first, when we have scarred cornea, of course, in the straightforward keratoconus patient with no scarring or just stromal scars, you will hardly can get mixed big bubble. You always get bubble type 1. When you have scarred in the cornea, the mechanics of air in the stroma differs, and when air sometimes is forced to go behind Dewey's layer to make mixed big bubble. This is the first cause, the scarred cornea. The second cause, I don't know the explanation, but I have a theoretical information that in macular stromal dystrophy, sometimes you may have the mixed big bubbles. So some advice in macular stromal dystrophy, there is no need to do big bubble. You may have big bubble type 2 with its risky rupture. So in this situation, the advice making stromal manual DALK from the start and don't inject macular dystrophy. So these are the two situations you are supposed to have mixed big bubbles or big bubble type 2, scarred corneas, especially Xanthamoeba keratitis or pest herpetic scarring, and macular dystrophy.
Yeah. And if we have the both complete bubbles, yes. Is it related to the AC depth? Maybe, I mean, in the first one.
No, I don't have any information about this. I think it has a relation to the factors I have mentioned before, the anatomy of the special case, the scarring, the macular dystrophy, but I don't think that has any relation with the anterior chamber depths. To the best of my knowledge, I don't hear.
I mean, I'm just thinking like in the first partial mixed bubble, there's not enough space to,
I have never heard about this, and I have never listened to anyone mentioning this. And in my experience, I don't think so.
Thank you very much, Dr. Tarek. I mean, we can like have all night asking questions and learning from you. There's a question, almost all lectures talking about types of big bubbles ask it, and it's related to phaco. So when we have disseminate detachment at the incision, So any advices, or could it be type 1 or type 2? And any advices how to not have it at the beginning or treat it?
Though this needs a surgeon to answer this question, but I think the detachment of the descent membrane at the site of the wound, this is a type, this is a just descent membrane, because dual layer is very adherent to stroma. It couldn't be detached except with air. So if you have this detachment, it will be just the descent membrane. And of course, there is some precautions to avoid this detachment. For example, don't have a tight wound, don't enter the anterior chamber with irrigation, make irrigation. And if you have such a persistent after the operation, of course, the solution was go and inject air to as if it is a DMEC case with detached DMEC graft. But
Thank
I
you
think
very
also
much.
again that if we have some a surgeon may make more tips as regard this complication.
Great. Thank you very much, Dr. Tarek. I will leave now the microphone with Dr. Mazen Sinjab. And I have a
Before
small...
you leave, Dr. Mazen, I would like to thank you also for you privileged me by your presence. Thank you for being here with us tonight.
Thank you, Dr. Tarek. It's a pleasure. And before leaving, I want to ask you and Dr. Mazen to add the third part of this like small complete series talking about manual DALK, if he accepts that.
Yeah, of course. Of course, first of all, thank you very much, Professor Tarek. It's a great pleasure that I'm attending as a student, of course, and thank you, Dr. Bara. But now, if we add this one, if you wish, we can make it after 2 weeks if your tight schedule allows, because we already all lectures are scheduled already. So if you want to add it, we are ready to have it after 2 weeks, if you wish.
Yes, of course. It's my pleasure. As I am the one who asked this, but I have to revise my agenda because in the next few weeks I have a lot of meetings. I will be going to Thailand next week for the Asian Cornea Society, and the 1st of December I'll be going to India for the Indian Cornea Society. And of course, I will meet you at APOMEC at the middle of December. So I think in the next month, I will be somewhat busy. I am ready after the middle of December to have this presentation, if of course, the schedule allows to have it.
Yes, of course. Now, the next cornea session in the series is scheduled to be December 10. Okay, the next presentation will be December 10, and the topic will be, let me check it now, and of course Professor Tarek, who will be the speaker, of course, and the next will be Big Bubble DALK.
Something is linked to DMEC or what?
No, Dr. Samer Hamada, stem cell transplantation.
Great.
It will be
great, because I will be in India at that time. I will be in India.
Okay, great. So do you want to make it after that?
Yes, I think we can make the proper arrangement with each other, Dr. Mazen, and then we declare it to in the group.
Yeah, we can announce it. But however, it should be before January, correct?
Yes, okay. I'm ready after the 15th of after finish of Kas Al Alam. World Cup.
Okay, great, inshallah. So we will arrange it together, inshallah.
Okay, inshallah.
So, yeah, at the end, of course, I would like to present my great gratitude to Dr. Tarek and Professor Tarek, of course, because he allocated part of his very valuable time for teaching us and for giving him the experience, which is, of course, very important, because we cannot find it in books, we cannot find it in even in videos. A great teacher, thank you very much. And of course, thank you, Dr. Bara, for moderating the session. Thanks for the attendees. And inshallah, within half an hour, it will be uploaded to the Academy YouTube. Good night, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you. Good night. Assalamu alaikum.